Hello, everyone, and welcome back to another dentistry session. Sorry, we are on the wrong slide. Okay, to another dentistry special session of Oral Pathology Tuesdays on Oral Pathology 360. Before we dive in, just a quick reminder about our YouTube membership filled with great perks like participation certificates. And we also have new members, one of who we are welcoming today, Dr. Anila Conneru. It's really nice to have you with us. And another important thing is, as you know, today we are hosting another exciting giveaway, a free registration for our upcoming virtual International Oral Diseases Case Presentation Conference 2025, which is scheduled from May 2nd to 4th. You will have to type IODCP 25 in the live chat when the time is there for the contest to begin. And you will have to also stay with us as we will do the live draw later during the session. This is our third one. Two people have already got the prize. Let's see if today you are going to get it. And the conference itself, of course, is a bag of goodies, and there are so many things happening, wonderful lectures, wonderful case presentations, which we have over 100 now, a 15 days replay. There's a lot of stuff happening. But among the many goodies is the one free pre conference track that you will get by registering, and you need to hurry so that you get the track that you want. Another interesting announcement that we have to make, which you already saw. A sneak peek of that is, as you know, we have an award now for the institutional award for excellence in learning and leadership. This will go to an institution or a dental school or a dental college, as we call it. And right now, the one leading is Manav Rachna Dental College. Of course, it is not just about registrations. Right now, we only have registrations, but going forward, it will also be about how many attend and, of course, participation. We are keeping on watching this, and the leader board will get updated as we go on. So keep an eye out and see if your institution gets there. Now, coming to today's program. Yes, it's yes, welcome. Patricia Pine is our guest today. She's a distinguished guest because she's internationally recognized speaker and expert in orofacial myology, something we have all studied a little bit, probably when we studied, of course, the myofunctional theories of growth and development. And now we are going to hear a lot more about it. This is something most of us dentists have sort of slightly left behind as we have moved on. And she is very passionate about what she does. She is an author and has written a book on this. With this, I welcome her. And hi, Patricia. Really
Hi,
wonderful to have you
hold
here.
on. Hi, good morning. We have some technical difficulties on this end of the world here. Good morning to everybody. For me, it's morning. For you guys, it's evening. Correct?
Yes, quite,
Yeah.
yes. We are
So
almost exactly 12 hours difference of time. So while it is a nice early evening for us, it is extremely early morning for Patricia, and we thank her for making this time. Yes. So
no.
I would also like to tell all of you that she has her screen open, totally covered with her presentation. So she really can't see us right now. So I'd much rather we go listen to her lecture, come back, and after her presentation, we will be able to have a more nicer discussion. Right, Patricia? I will take you to your lecture. Okay.
Okay. Thank you. All right. Let's get this rolling here. I have a few disclosures. See, I don't know why it's not cooperating. Here we go. There we go. Hello, everyone. Thank you for joining me for What the Heck is Orofacial Myology, aka Myofunctional Therapy? How can it increase your production? Well, I have a few disclosures. I am the owner of Muscles in Harmony, providing oral facial myology. I'm a certified oral facial myologist per the IAOM, and an Upledger trained craniosacral therapist. I am the author of Please Release Me, the Tethered Oral Tissue Puzzle book. I do receive payment for her book to pay for the printing and intellectual knowledge. And I am reimbursed for my speaking engagements. Not this one. This one's on me. I'm also on the IAOM board in a variety of capacities, and on the many committees and past newsletters and conventions. IAOM is the gold standard of myofunctional therapy. To get your certification, it is a mastery level of distinction of OMDs. After assessing written and clinical knowledge, awards the student certification. This year in 2025, we have an annual conference in Salt Lake City, Utah. If you're interested in joining us, we'd love to have you. And this is Discover the Myofunctional Therapy Puzzle Head to Toe course. I am an instructor, and we do have some courses coming up, one in May and one in November. The November one is virtual, online. Here is the book. You can reach this or purchase this on musclesinharmony.com, and then I will ship it to you. Slides are copyrighted, so if you can just view the slides and not take photos, that would be appreciated. I don't know why it's not cutting. And I'm also a national and international speaker on topics related to dentistry, including OSHA safety, infection prevention, and COVID safety. I've expanded my education to include myofunctional therapy. It's driven by passion for helping others maintain their smiles. This led me to create Muscles in Harmony, where I provide neuromuscular training to help balance the oral complex of muscles. I'm very passionate about how the tongue functions with the body, as you will see in today's program. Myofunctional therapy uh, okay, listen, and now how do we get it where, um so I'm sharing my screen here. Okay, let me hide this, and, um, what am I doing here now? Mhm. Um, about me? Okay, so alright, and then how do I over here? And then, hold on. I need to, but then we need to start from current slide.
I
Is
invite you
that
to join our course in May in Lake Geneva, Wisconsin, or November, which is virtually. We have a lot of fun. There's supplies. We have a lot of challenges. We do puzzles. It's a lot of fun. Myofunctional therapy is going from the imbalance to a balance. When you think of the body, you think of it as being straight up and down. Well, that's not always the case. And so we're going to dive deep into what's causing all these issues and why myofunctional therapy is a thing. Never used to be, but we have found out that is underutilized. Here are the objectives today. I'm not going to go through them because you've got them, but we are going to discuss quite a bit. So here's the history of orofacial myology and dentistry with Dr. Edward Engel. If you recall, he does all the class one, class two. He recognized influences of the facial muscles on malocclusion. He believes that the mouth breathing was the chief etiology factor in class two, division one malocclusions. Just understanding how common this is and how the skeletal growth could be influenced readily by external pressures. Proper function of the dentition would be key to maintaining teeth in their correct position.
Oop.
So here's just a timeline of how myofunctional therapy got started. It's becoming very popular. There's a lot of offices that are putting into their practice because they see how much benefit it is for their patients, but also for their dental work. The tongue can knock out crowns, the malocclusion can knock off crowns, break teeth, things like that. We're going to go ahead and move on to the why or what's going on with the evolution of our skulls. So, Daniel Lieberman, who's a human evolutionary biologist, he believes in being a hunter gatherer. Well, that's what we used to do years ago. And years ago, we used to go and run for our food and non meat bones. We used to gather all our food, our seeds, or our fruits and vegetables and our farmers. So we're cooking and processing and tenderizing. Now we have the industrial era of mushy baby food, soft foods, French fries, chicken nuggets, nothing on a bone, and we're not using our jaws. So you're going to see that what we did in the past has really helped the jaws grow. What we're doing currently and hopefully change in the future will help our facial features and our digestion. So, new oral health information. We have a lot of research on myofunctional therapy, and the Oral Health in America report from the Surgeon General has stated that oral health means more than just healthy teeth. We need healthy gums, healthy bone, healthy jaws. And then we have freedom from chronic oral facial pain. We want to be healthy and functional in the cranial facial complex. And oral health and physical health are connected. The report used the phrase, the mouth is the mirror, regarding that oral facial myology disorders correlate with general health. And we will soon find that out. The ADA, the American Dental Association policy on sleep related breathing disorders, myofunctional therapists screen for all these disorders of the sleep. And we ask a lot of questions and we screen for sleep related disorder breathing. daytime sleepiness, choking, snoring, witness sleep apneas, waking up coughing and choking. Work with a physician to determine if you have OSA. And we develop optimal physiological airway in children. And we're sleepwalking, nighttime terrors are all signals that something's going on in the airway, grinding and clenching. Current ADA recommendations are oral appliances or a CPAP machine, which I personally feel is a Band-Aid. Let's get down to the root cause. What's causing all the sleep disturbances besides stress? Orofacial myology disorders and overall health. We have 1 in 10 American has sleep apnea. 80% are untreated. They have no knowledge that they have a sleep problem. They will make an excuse of, oh, I just worked late. Oh, I've been so busy. There's a lot of things going on at work. So we want to make sure that what's going on is really for the best interest of the patient. The TMD is common. People have jaw pain, and it's usually when they're grinding and clenching. And it's sometimes stress. It could be other things. It could be malocclusion, and their bite is trying to align itself. The way we breathe, sleep, and hold our tongue in our mouth impacts the quality of our lives. Here's another article that you have the pleasure of reading. I just pointed out some highlights that the 2013 World Sleep Congress in Spain had 5 presentations that referred in some fashion to myofunctional therapy. And then we have myofunctional therapy to treat obstructive sleep apnea, a systemic review and meta-analysis, which you can read at your leisure. Evidence base is growing as a standard of care for myofunctional therapy. 2012, we have the PubMed articles. 2022, there's over 1,000 articles. In fact, IJOM.com, which is on the International Association of Orofacial Myology, has a lot of articles, great research if you're interested in going to that venue to find out more information. We have a lot of evidence and guidelines. We have textbooks, and we have variety of multiple books that I have. I've never had such a big library in my life, but I keep getting deeper and deeper. I keep reading, and I have now figured out I am totally a nerd. But I'm very passionate about what I do, and I want to help people live a healthy life. So orofacial myology involves all the muscles of the face and the neck. As you can see that the muscles, the sternocleidoid mastoid muscle goes down to the collarbone, and we can turn our head, and if it's not comfortable, it could be our bite. Our occlusion, malocclusion affects everything in our body and our tongue, which we will get to shortly. Who can provide orofacial myology? Well, they need to be trained in orofacial myology via the IAOM if you want to be certified. So it's licensed dental hygienist or dentist, speech language pathologist, occupational therapists, and physical therapists. They all have the background knowledge and the education behind them to go ahead and move forward in orofacial myology. So, what is orofacial myology? It's the method of restoring a normal action of muscle groups related to the tongue function and swallowing. Orofacial therapy is a program used to correct the improper function of the tongue and facial muscles at rest for chewing, swallowing, and speaking. So, when you think about it, myo is the muscle, and oro is the mouth, and the face is the facial features. The neck is oropharyngeal. Neurological reeducation of the facial muscle movement. So we take unbalanced facial muscles and get them balanced, and we use specific exercises. We're harmonizing the muscles for normal craniofacial development and function. We have a plethora of research and literature from 1918, and we provide therapy to assist treatment for the development structures of the mouth. and the neck. You must remember that muscle trumps bone. Unaligned or not in harmony and they're not working together, you could get an asymmetrical facial features. Myofunctional therapy is holistic. It's non-invasive exercise-based therapy. It's muscle therapy for the mouth and the face. And we present exercises that are specifically designed to repattern neuromuscularly muscles for proper breathing, speaking, chewing, and swallowing. These are 32 myofunctional disorders. We cannot go through all of them, but typically most of these have a tongue connection with them. So we will go over that shortly. Orofacial myofunctional disorders with the craniofacial complex can affect many things. This starts with birth, with breastfeeding, the facial skeletal growth and development. It affects chewing, tongue thrust, swallowing, mouth breathing, facial aesthetics, oral surgery, low muscle tone. So if we have all these disorders, these are all things that come in a bundle. Not everybody has them, but this is why myofunctional therapists do a really thorough assessment and evaluation. My evaluation is 2 hours, but I watch everybody chew, swallow. We test everything. I watch them walk. I want to see their posture. Postures are all correlated to the entire body, the neck, the shoulders, the knee, the hips, the knees, and the feet. So here is some other symptoms of disorders, myofunctional disorders. We have open mouth at rest, which would also be called mouth breathing. We have allergic shiners, messy eating, drooling, digit sucking, pacifier habit, malocclusion, articulation is wrong, speaking articulation, mouth breathing, tongue thrusting, and tongue sucking. But myofunctional disorders are similar but different in children and adults. If we can get these kids early in life, like 3, 4 years old, we can guide the muscles to have them grow and develop the jaw and the face. So disorders of the muscles, functions of the face and the mouth, disorders may affect directly or indirectly. Of course, breastfeeding, it all starts at birth. Facial skeletal growth and development, chewing, swallowing, TMJ movement, oral hygiene, stability of orthodontic treatment, facial aesthetics, and much, much more. So orofacial myologists provide this service, and it works well with all age groups. We work with tongue and lip ties, tongue thrusts, mouth breathing, chewing, swallowing, and all these disorders, some way or another, are connected because the muscles are connected and intertwined. So if somebody is eating a terrible, is not having good nutrition, then they typically are not going to have or we want that jaw moving forward. And so we want a lot of orthodontists in today's world are bringing us forward and wide so the tongue fits up into the palate and we can occlude correctly. So myofunctional therapy can include airway, breathing. We want tongue to work on their own. We don't want them to work. They essentially work together, but if the jaw is moving the tongue and it's anchored, the tongue is anchored to the floor of the mouth, we are not going to be able to disassociate that tongue. So that's part of it. Lip incompetence, where we have a lip tie and we have a short upper lip, and we'll go through that. Physical posturing, so sitting up straight, standing up straight, also correlates to tongue posture. The lips, the tongue, and the jaw all have to work together, but we want them also to work independently. Parafunctional habits, which would be thumb sucking or pacifiers, tongue and lip tie, be ankyloglossia, abnormal swallowing, a reverse swallow, and infection control and prevention for all therapists. So here again, we have a lot of benefits that myofunctional therapists do. Oral surgery, we support all surgeries. Orthognathic surgery, MMA surgery, maxillary osteotomy, all this type of surgeries are helped by the myofunctional therapist because we get the muscles prepared before and after any surgery. When you think about it, surgery, they're going to be cutting fascia, they're going to be cutting muscle, and we want to make sure that the muscle knows its muscle memory before and after the surgery. So it's very advantageous for a patient to see a myofunctional therapist before any surgery at all in the mouth. Myofunctional therapy is not physical therapy or occupational therapy or speech therapy. It needs to be made clear that it is a modality of treatment. Observing disorders, if the tongue rests low in the mouth like this, which is also cause mouth breathing, thumb sucking, finger sucking, airway issues occur. And then we have that tongue that's scalloped. It's saying that the arch is too small for the tongue, and the tongue needs room to function, which is sucking, lip biting, pacifier use, nail biting, lip licking, which is a bad habit, facial mannerisms, people make faces as they talk, and malocclusion. The goals of an orofacial myologist is we'll assist with orthodontic relapse. We see a lot of orthodontic relapse, and why? I believe it's the muscles. The muscles are not in harmony, and the tongue is not cooperating with the rest of the body. Breathing disorders, sleep disorder breathing, craniofacial and neck pain, headaches, pre and post surgical healing, and headaches. And then we want to eliminate orofacial disorders, and we want the patient to lead a healthy life. Here's a myofunctional goal: is we want nasal breathing only, jaw stability, oral rest posture for the tongue and the lips, and correct swallow, physical correct posture, eliminating muscle dysfunction into muscles in harmony. Dysfunction influences are on the dental occlusion, facial shape, and anatomical concerns, chewing, swallowing, along with the tongue, lip, and jaw, and physical postures of the body. The tongue is the CEO of the body in many ways. The tongue tells us it's the ultimate judger of food. It does what it wants when it wants, and it hunts for pathogens. So we have the lingual tonsils that help us out there. And the tongue is the CEO of the body in my eyes. The body controls each body system we have. Have you ever thought of that? We've never looked at the tongue this way, but the tongue assists in nutrition, speaking, chewing, and swallowing. It balances the body when in the palate. The tongue lets us know what it does and doesn't like for nutrition or not. And it's involved with breathing, mood swings. It's let us know when we are sick by the color of the tongue, and much, much more. The tongue's action is not confined to the oral cavity. It can affect the circulatory system by oxygen, the respiratory system by sleep apnea, nervous system by the behavior like ADD and ADHD. We need to make sure that our nervous system is in order and that we are parasympathetic and not in sympathetic mode. And muscle system, we need orofacial development, function, and speech. The skeletal system is the palate and the jaws, and the digestive system is known by colic, reflux, or gagging. So all these systems work with the tongue. The CEO of the body is linked to physical health, as I just mentioned, the eye's neuroplasticity. So we have the patients look into a mirror. The eyes tell the brain, makes new pathways in the brain so we can make new patterns of the tongue and the function of the tongue. Dysfunction of the genioglottal muscle will also affect the tongue function. Digestion, circulation, respiratory, nervous system, and muscular system. They all play a role with the tongue. The anatomical relationship of the tongue with the body system is a terrific article. The tongue is a fascinating focal point for a diverse array of professionals. Changes in the muscle properties of the tongue can reveal important insights into various health conditions. While systemic disorders may impact the tongue, as a secondary effect, local alterations can also have far-reaching implications for overall health. Conditions such as scleroderma, local tongue dysfunction, tumors, and effects of aging, obstructive sleep apnea syndrome, and the emotional disorders all underscore the intricate connection of the tongue health and our well-being. Well, did you know that tongue fascia connects to the toes? So when you figure, when we are created, we have all our organs and bones and arteries and every ligaments all on the bone. And then think of Spider-Man. He comes and he throws a spider web over all our bones and organs. And then it's the human body. Then they put the skin on top. Well, if that fascia is too tight, it can be too tight from the tongue all the way to the toes. So, and the posture, your body posture, you can have sore shoulders, sore neck, and it can be from the fascia. So myofunctional therapists look into this and we watch your posture like a hawk. Because if you have a crooked body, you have a crooked neck, you have a crooked jaw, and you have orthodontics, you could have crooked jaw with orthodontics that is not on a straight neck. So there's 3 layers of fascia: a deep, middle, and superficial. It's pliable, sticky, and movable in health. Replicates human body and connective tissue that holds every organ and muscle in place. Adults may maintain effects of fetal rotation in adulthood because of fascia. And the fascia is the place to look for the cause of disease and the place to consult and begin the action of remedies in all diseases. The tongue connection to the hyoid bone. Well, as you know, the hyoid bone's right under the chin, along the neck, and it connects the tongue to the whole body via the fascia. So remember, we have suprahyoid muscles and infrahyoid muscles that connect to the tongue. And when the tongue is tight, this hyoid bone can be very tight, which is why we refer our patients to a craniosacral therapist. Body will say for a body. Sometimes it just wants to break loose. About shortly. The tongue's connection to the body. The tongue serves as a natural architect for the maxillary arch. So naturally, the tongue is a natural expander of the upper arch and expanding it effortlessly. However, if tethered, it loses the ability to reach the palate and fulfill its essential role. During a mature and functional swallow, the tongue plays a vital role in enhancing cranial motion and facilitating the unwinding of intricate cranial strain patterns. In this complex process, the tip of the tongue exerts gentle pressure on the spot located just behind your front teeth. This action causes the vomer bone to lift slightly, transmitting a ripple of motion to the base of the sphenoid bone. This bone, in turn, is connected to the occiput through the sphenoid basilar symphysis. Such motion occurs just below the sella turcica, a crucial structure that houses the pituitary gland. The subtle pressure generated by the harmonious contact between the palate and the sphenoid, stemming from the activities like chewing, swallowing, and speaking, creates this dynamic pumping action, beautifully draining action from the middle ear and maxillary sinuses. This intricate process also influences beautifully structured sella turcica, underscoring the profound connection between the mouth and the brain. Remember, if the tongue is not doing its job, none of the above motion will occur, and the body compensates for the lack of pressure on the palate, the sphenoid, and the occiput. The body is well-disciplined machine when the tongue functions as a normal, as a mobile, healthy organ. Important. So we have a Gothic arch the tongue won't fit in, and then we have a wide arch the tongue should fit in. So which would you rather have? Our goal in today's world is 50 millimeters across from the lingual of the first molar to the lingual of the second molar at the gum line, measuring. But it also what also we need to determine is the buccal plate of bone. Will it suffice to expand the maxillary arch to a 50 millimeter expansion? So symptoms and health concerns are grinding teeth, TMJ, clicking in the jaw, snoring, food trapping in the palate or gums. These are all common health concerns or symptoms, that we need to be aware of as myofunctional therapists. There's a reason all this is happening, and it's typically muscles. So remember, muscle trumps bone. We have form follows function. If you see what's happening in these photos, we have underdeveloped maxilla, mandible, and then we have a tongue thrust. And that tongue is actually pushing those teeth out of the jaw. And then we have the effects of food processing, which I touched on earlier. If we can't chew our food, our jaws will not grow, and we will have a retrognathic face. The results support the hypothesis that food processing techniques have led to the decrease in facial growth in the mandible and maxillary arches in the recent human population. So when to evaluate frenums? Best time is when you have an oral cancer exam, because you can, as you go through the entire mouth with your fingers, you can check those 7 frenums. Oral Cancer Awareness Month is April. Here we are. So seek and find and then refer. Don't wait and watch. So we're going to diagnose some tethered oral tissues. You can see how short this frenum is, and this patient is grinding and clenching, which also shows us that she has bilateral mandibular tori from grinding and clenching. So here are 7 frenums. We have 1 in the front. We have 1 on each side of the buccals around the first molar, second bicuspid area, and also the same on the bottom, and then the front labial frenum, and of course the one under the lingual frenum under the tongue. So we want to make sure that those lingual frenums, buccals, and all frenums are loose and functioning. So tongue tie is also called ankyloglossia. It's a congenital tip of the tongue, can't protrude beyond the lower incisor teeth. That's what we were taught in school. That no longer is the case. You can stick your tongue out all the way and still be tongue-tied. Tongue tie can also cause speech problems. It's a surgical procedure called a release. We want to seek an experienced dentist or ear, nose, and throat doctor that gets it, that understands what tongue tie is. Many doctors were not trained on it, so they kind of don't understand that this happens at birth. It can cause feeding issues, swallowing, chewing. Kids that have tongue ties usually prefer soft foods, fries, fried foods, macaroni and cheese, chicken nuggets. Kids in speech therapy in schools are underdiagnosed. I've had children that have been in speech for 5 years. I had one child 10 years, and they will never get their R's or their S's or their lists clear unless they see a myofunctional therapist that knows how to diagnose a tongue tie. So we have infants, children, and all ages that there are symptoms of tongue tie that we are finding more and more out every every day. I have adults and children as clients, and it's amazing how it changes their life once they have their tongue released. Problems can all start at birth. The trouble, which starts with trouble breastfeeding or bottle feeding, and then they're not swallowing, they're losing weight, they're gassy, crying, they're not happy babies. And then as they get older, we have a lot of issues with speech, eating, swallowing, breathing. And then it causes stress throughout the entire family. But now you can see how this little baby could have torticollis, which is muscles of the neck that are torqued, and other things that could happen. So it's a shame, but everything we need to look at, if we see the baby right after birth and we diagnose a tongue tie, that's the time to release it. Nutrition, ankylosing, and breastfeeding, you can see that this baby's upper lip is not flipped. So in order for that baby to get enough negative pressure while breastfeeding, that lip has to flip. And she gets inefficient suckling, limited action of the tongue, lengthy feedings. They usually fall asleep, and their failure to thrive. And they're very unhappy. They're crying all the time. And mom switched to a bottle, which then is lack of bonding with mother and baby. Sometimes we can see a bubble palate because the baby is not breastfeeding. We see that high palate and that tongue tie. You can see the little dimple on the tip of the tongue. That is an observation stating that the baby has a tongue tie. The breast is not supported on the top for compression because the baby has to push the tongue with the nipple right here, and this is the tongue, and the tongue can't reach up because it's anchored to the floor of the mouth. So if you're observing a heart-shaped tip of the tongue, the baby can't extend out to a point. The tongue curves downward, usually leads to a deviated swallow. We have speech problems, swallowing pills is impossible, digestive issues, can't lick an ice cream cone, which is sad, unable to French kiss. So symptoms observed or should be reported or referred to an orofacial myologist. So when a doctor diagnoses a tongue tie on a child or infant, they want to lay their head in their lap, typically with the mother's knee to knee with the mother or father, so the baby can see somebody that they know. And then they do stretches, which you bring the tongue or the lip up and down. So that's something that needs to be trained in a course. Here is a class 4 tongue tie. This tongue tie will never be able to breastfeed, prevents the lower jaw growth because the muscle trumps bone. We have clicking during feeding, poor weight gain, gassiness, upper lip callus, and future speech problems. It all starts at birth when the frenum attaches to the floor of the mouth. It can be too short, tight, or thick. Researching is saying that there's a lack of folic acid in the mother, and currently I've read and heard it's too much folic acid in the mother's multivitamin. It is more common in boys and girls. And then there's a lot of midwives used to clip tight frenula on newborns with their fingernails. They would take the longest fingernail they had, and as soon as the baby was born, it was cut or sliced. But now they're stating that it's unsanitary by present standards, and it was effective. But now they're saying that insurance gets involved in today's world also. So the definition of a frenum or frenulum is a fold of skin or mucous membrane that limits or controls the movement of an organ or body part. The small piece of pink tissue attaches to the floor of the mouth and anywhere under the tongue. So here again, the tongue is the main organ system in our body. It affects babies just like it would an adult. And it's very sad that the family has to go through this until it is diagnosed and the tongue tie is released. So here's more articles on tongue ties and sleep issues. That baby is mouth breathing. That's not healthy at all. So tethered oral tissue ankylosing. Here is a very severe class 4. Abnormal speech, heart-shaped tip tongue, head posture. You look at the head posture, stomach aches, gassy, reflux, clicking noises, pain when breastfeeding, crying, unsatisfied, and not in those sequence. It was suck, swallow, and breathe. The baby has to suck, swallow, and breathe. Here are just some more photos of some tongue ties, ankylosing that are pretty severe. And we didn't know what we didn't know. And those little arrows on the upper right photo are the salivary ducts. We don't touch those. Here is just a demonstration of how to identify and classify, which is what we do in today's world, the Eiffel Tower, class 1, class 2, class 3, and class 4. This is how you would report your tongue tie. Here's a very severe class 4. Here is some more case studies and case reports. Here is some tongue tie facts. It ranges from 2.8 to 10.7% of the infants born have tongue ties, more common in boys and girls. It is genetic. As I said in the past, we have abnormal chewing, swallowing, can be very emotional. It hurts your self-esteem when the kids go to school and they can't speak. Frenum feels tight on palpation. The shoulders are tight, the neck is tight, or the neck is to one side. There's a lot of symptoms involved here. We have excess saliva, speech impairment, tongue position assists in growth and development. As I said, the tongue is the natural expander of the upper arch. If it doesn't get up there because it's tongue tied, the teeth will come in anywhere they want, and it lowers self-esteem. You can identify tongue tie. I can see a tongue tie a mile away, but I'm very versed in this. The tongue can flip. It wants to flip to one side. The fiber can be thin. It can be visible during speech. The tongue cannot clean the teeth in the back, the posterior teeth. There is some bedwetting, the apnea, which is also an apnea signal. We have hypersalivation, slow, fussy eater, inability like the ice cream cone. And then what's a normal frenum? Well, it's one that doesn't create problems while nursing or bottle feeding. The tongue forms in the palate in a horseshoe shape. The patient doesn't drool all over. Sometimes we see drooling upon eruption of baby teeth. The person has a clear speech, tongue moves food side to side, a normal eater, not messy, enjoys that ice cream cone, and loves hard food and fresh vegetables. So myofunctional goals is that we really want nasal breathing, lips closed, tongue on the palate, and correct swallow. And we want to eliminate any of the disorders so that we get these 4 main things. And here is one way to screen your patients. And here is another screening tool that Dr. Zaghi from LA, California, in the United States has developed. And then we're going to go ahead and check yours. If you have your standing mirror ready to use, you want to open your mouth and without closing your jaw, try to reach your palate with your tongue like that, and take a photo and see what you get. Take a selfie of your tongue, and with your mouth open again, point the tip of your tongue to your throat, way in the back. So it's doing a back bend. Take a photo. And can you suck your tongue to the palate like if you're doing a click? Then hold it up there and take a picture. The floor of the mouth, and are you a class 1, 2, 3, or 4? We will be viewing some of the tongue and the lip frenums coming up shortly. So there are different screening tools that you can use. I can't go through all of these. We don't have the time. And then you never, never, never want to stick your head out the window at 95 miles per hour, because that's what could happen. I don't think our tongues are that long, though, but it's pretty cute. So we have a risk of dental decay with lip ties. So a lip tie can pack, that food can pack right up there, or milk, and then we have problems with decay. And then we have tongue in a lip tie, which can cause nipple pain, uneven breast drainage, short upper lip, and what I mentioned earlier, when the lip of the baby doesn't flip, it can't get the suction in order to get a nursing and the negative pressure. So we have a tight frenulum restricting effective breastfeeding. And here are just some photos of some tethered oral tissues that we would release. And then on that bottom right, we have some buccal ties. When the baby has buccal ties that are too tight, they also cannot get the negative pressure when sucking, eating. And sometimes that can be why the child is a messy eater, because these buccal frenums are way too tight. And then we have lip incompetence, where the patient, even though they try, they can't get their lips together naturally. And so when that happens, we usually look, and the lip frenum, the maxillary lip frenum is way too tight. And so we want to get that released. And if the lips are frenums are too tight on the upper maxillary, you have a healthy smile.
Sorry about that.
And if the lips are frenums are too tight on the upper maxillary or even the lower, we get gummy smiles. And gummy smiles are not a good thing. And you can see how that occurs. And so we want everybody to have a healthy smile. Who provides frenum releases? Well, oral surgeons, some dentists that are trained, and many dentists in the United States are trained by Dr. Zaghi in LA, in California. And we refer. So I usually send photos with all my referrals so that the doctor knows what I see and we're on the same wavelength. And then, you want to interview your provider and you want to know what tools he's using. So we recommend the light scalpel or a CO2 laser. I'm not marketing this laser. It's just one that I know of. And it's less bleeding, less swelling, less discomfort, less infection risk, and less invasive. It's very quick to do these releases. In 1960, the carbon dioxide laser is minimally invasive, does tissue surgery. A diode laser leaves too much scar tissue, so we prefer not to use that. We prefer a CO2 laser. And scalpels, which is many of the doctors were using years ago, is way too much bleeding. It reduces your vision and a lot of post-op discomfort. They all use local anesthetic. The disadvantages of scissors is limited view, additional surgery to view a revised tongue if it has to be done a second time, edema post-surgically, heavy bleeding, and pain post-operatively. So how the release is accomplished is they use this tool to hold the tongue back, and then they use the laser in between the frenum and the Wharton's duct. And pre and post surgery stretches are a must. If you do not stretch for 4 to 6 weeks before the release, the tissues will reattach. I've seen it happen on the best of patients. Specific stretches are given for 4 to 6 weeks before release and 6 to 8 weeks post release. And this tissue will not heal for, at least within the tissue, won't heal for 1 full year. The outside is a diamond and it fills up with granulation tissue and connective tissue, and that's what we want. And the more, the bigger the diamond, the better, because then the tissue will fill all that in and will get height on the the tongue. That's what we're looking for, is more height. So the tongue should be able to touch the back of the anterior teeth and the maxilla, about a half inch from the teeth, very comfortably. So the tongue fits up into the palate. So here is one view of some tissues. Some doctors do sutures, some do not. If you do sutures, you don't do the stretches for 2 days. Otherwise, you're doing stretches right after following it. I say about an hour to 2 hours post release. Without good form, we won't have good function. We have parafunctional habits, as thumb sucking, finger sucking, and pacifiers. These all damage the developing palate, jaws, and skeletal structure. Here's somebody who clenches and grinds and bruxism. Could be because of the tongue. There's no room for this tongue. You can see the very narrow mandibular arch. The teeth are not in alignment. And then we have those huge bilateral tori, and then we have the frenum smack dab in between them. And that can hurt with eating. Here is a very nice frenum it's got 3. It's very thick. This would be a very good release. But you can see the floor of the mouth is raised up and pulling on that. So we definitely know that there is a frenectomy in this patient's future. The tongue is the CEO of the body. Why? Because it's oral development for chewing, eating, chewing, speaking, sleeping, breathing, and French kissing, which we all do as adults. Airway is number 1. Without a patent airway, which means a clear airway, what do we have? We have a lot of health problems. So snoring and sleep apnea and mouth breathing, you can see in all these photos, they all have issues. And we have depression. We have a high risk for heart attack, high blood pressure. Hormone imbalance. We can have a stroke. We have plenty of snoring. We need to be sure that in these, whatever these patients are wearing on their chin, I actually had a patient that tried that and it hurt his TMJ. So mouth breathing disorders is because they have nasal congestion, enlarged tonsils or adenoids, enlarged turbinates, enlarged nasal polyps, or mouth breathing is obligatory. Mouth breathing is open mouth breathing, prevents the mid-face to grow, and we have a narrow palate, long tongue, low tongue posture, creates abnormal development and TMJ concerns and periodontal infections. So tongue thrust usually equals an open bite. You can see where the tongue is thrusting forward because number 1, there's no room for it. Number 2, it's not swallowing correctly. Typically, these kids or adults have a tongue tie, and the tongue is preventing that tongue from normal swallow. Tooth eruption, I have kids that have had braces or are going to go into braces, but those teeth won't come down. Well, those teeth won't come down specifically because the tongue is thrusting where the space is. So it's a bilateral open bite, and the tongue loves to get in there. So the tongue goes this way, it flanges out. Where am I here? And the tongue wants to get out, so it's going to do it any which way it can. Here's where the tongue should be going 24/7 unless you're eating or talking. It should be the tip of the tongue and gradually getting the entire tongue up into the palate. Open bites are because there's incorrect movement of the tongue and the resting posture of the tongue. So if you have your standing mirrors and straws ready to use, take your small black straw and breathe through it for 1 minute. We don't have time to time you, but you can practice this. It's very hard to breathe out of that little black stir straw. Now take the larger straw and breathe in and out of it. Some kids or adults don't have a large airway and it affects the brain. So when you're breathing out of a little straw, even the larger straw that you have, you're not breathing enough. You need to breathe through your nose because we have that warm, humidified air going through the nostrils, and we need to breathe through the nose. And if we have a small airway, which we can notice while we're doing our assessment on a new patient, they have a small airway and probably have a lot of other issues or disorders. A lot of kids mouth breathe because they're enlarged tonsils and adenoids. How do you breathe? How do you swallow? How do you swallow food with that? So mouth breathing versus nasal breathing. Nasal increases the oxygen that flows into the brain with the nitric oxide as a vasodilator, humidifies the air, warms and moisturizes. The mouth, it's a lot health risks. A lot of kids get sick because their mouth breathe. Nasal congestion, deviated small nostrils, and the tongue in the airway. Myofunctional disorders, they can't pronounce their consonants. Patients usually with a tongue thrust, thumb or finger sucking, lip licking, lip or cheek biting, external pressures. Remember, muscle trumps bone, so if they're always doing something with their cheeks, it could lead into abnormal arch shape. We have bruxism, excessive mouth breathing, and abnormal lingual or labial rest postures. Here is a child where the midface won't grow because she was a definite mouth breather. You can see her chin is retruded. She has a forward neck posture, and the kids do forward neck posture so that they can breathe. That's the only way they can breathe. And then we have behavioral issues. When kids can't breathe, they don't know what to themselves. So they act up. That's their only way to get attention. Nobody knows why. Typically, it's they're not breathing properly. Dangers of mouth breathing is low tongue posture, dry mouth, gum disease, sleep disorders, overbreathing, swallowing issues, and a Mallampati score of a 4. So what do you see here? You see in the top left, very good definition of cheekbones, straight nose, straight jaw, a well-developed jaw, and a good airway size. And then down below, you see this person with the ears are flanged out, their narrow face and crooked teeth and tired eyes. So craniofacial changes in mouth breathing, it happens. If they are not breathing through their nose, their face will change. And it also occurs after orthodontics, after the parents have spent a lot of money on their orthodontic treatment. And somebody is not, the mouth will change. It will go back to where it was originally. Orofacial myofunctional therapy assists patients for a healthier life. Here is some more articles that you can read at your leisure. We also request a 3D CT scan for observations to see where that airway is. We want an airway for a person in trouble on the left, and then we want optimum 20 millimeters on the right. The bigger the airway, the better. Then we have TMJ and TMD from an anchored tongue that's always pulling the styloglossal muscle, prevents stimulating of the development. Pressure of the tongue is what develops the jaw in the face. Can't reach the palate, high vaulted, narrow palate, create underdeveloped jaws and airway. Temporalis muscle or the cranium is locked. The lip ties draw the lips back onto the teeth and the resisting outward growth of the jaws. And when a tongue tie is untied, it increases range of motion and promotes proper facial.
Are you kidding me?
Then we have TMJ and TMD development. And then I have no special talent. I'm only passionately curious, which is a fault of mine, but I love it. We have orthodontic therapy. Let's go over this quickly. I'm running. We have orofacial myology, assists with orthodontic relapse. Muscle trumps bone. Muscle always wins. So if that tongue is tied, that lower jaw tied to the bone, like Eiffel Tower, that jaw is never going to grow forward. And you'll see that more and more now that you're aware of what to look for. Structural abnormalities We have maxillary underdeveloped jaw because of tethered oral tissues, which is TOT. And then observations reveal we have the crooked nose, we have the mouth breathing, narrow face, bad posture, small airway. These kids are in a lot of trouble. And I want you to kind of think out of the box. We just can't think of the mouth as just teeth. We really need to look at the whole picture, the body from head to toe. How does orthodontic therapy affect the cranium? Well, here we've got the cranium is locked in place when braces or expanders are used. So the cranium cannot breathe and function like it's supposed to. There's a rhythm to the cranium. And then we have braces are fixed to the cranial sacral system and it pumps and its pumps are in a state of contraction. It can become locked in this state. If the braces are applied in a state of expansion, resulting in the rest of the body becoming stuck in a certain patterns, twists, or imbalances, causing pain in the jaw, the pelvis, the skull, and the upper palate. The sphenoid bone is one of the prime movers of the cranial sacral system. But when we put braces on all these teeth and we lock that system, the skull is also restricted. That's why cranial sacral therapy is so important before you put any braces or appliances on any patient. What is a cranial strain? A pattern of compression in the facial and cranial bones that can cause a variety of effects on the body and mind. Cranial strains can unleash destructive energies upon the body and the mind, causes malfunction and dysfunction of the cranial nerves in the face. Cranial strains can be caused by a number of things: traumatic force to the head, circumferential compressions during birth, or severe depression. Any trauma remains in the spinal cord, in the dura, and it drains the immune system. Dental professionals need to think beyond the teeth. What's going on in the cranium? These bones move. Here's your lovely sphenoid bone, which is a single bone that connects the neurocranium to the facial skeleton. The sphenoid is the keystone to the cranium body. Osteopathic strains caused by dental occlusion. These strains are caused when and only when the occlusal surfaces of the teeth come into contact. They are not present when the teeth are separate. Osteopathically, these are dental in origin and result in occlusal strains. So here we have this sphenoid basilar symphysis, where the occiput and the sphenoid are connected. And if the swallow isn't right and everything's not in alignment or in harmony, we can have headaches and trauma and migraines, etc. Here's a Stanford study that the myofunctional therapy is poised to take off. Oh, it's taken off. We have a lot of myofunctional therapists. I see patients online and I see patients in person. So it depends on what the patient needs. I go to whatever is best for the patient. Here are some books that I highly recommend you read. And here are some more. Breathe, Gasp, Jaws, The 6-Foot Tiger and the 3-Foot Cage is all about the tongue. And this best book ever to learn how the body and the oral cavity connect and move together with the cranium. I thank you for your attention. Who can be a patient? Anybody with a tongue or any oral disorders. I thank you so much for your patience and your time with me. And I think we went over the treatment of the tongue thrust, mouth breathing, nail biting, TMD, and more. I'm happy to help your patients. And anybody who has any questions, please don't hesitate to ask. I don't think I put my email in there. It's info, INFO, at musclesinharmony.com. I thank you. You are the missing piece to the myofunctional therapy puzzle. Refer your patients to an orofacial myologist that does myofunctional therapy, and they're certified. I thank you.
Okay, are you still there?
Have you finished sharing so that you can now see the screen?
Yes.
Okay, wonderful. All right, let's. That was a very thorough and very extensive lecture, but very interesting indeed. It is very interesting, and it is very interesting to know that so much is connected, uh, right from breathing to the tongue to the TMD to essentially the whole body. And it was a very eye-opening lecture indeed.
Good. Thank you. I hope
Welcome.
everybody got a little piece of part of it. There's so much information. Um, it's amazing to me, why we didn't learn any of this in school.
Quite. It happens. Some things just sort of get left to the side.
Hmm.
So let me tell everyone you enjoyed the lecture. Do hit the like button. Do also put in your comments and questions here in the chat so that we can deal with those. And also begin typing. Let's just go for a moment to this other image and then we will come back. Mhm. So, everybody, we are having the giveaway. And while you type your questions, also remember to type uh, in the chat hashtag IODCPC25. We will shortly have the draw, and then one of you will get a free registration for the conference. So, this is just so that you can do this while we get ready. And okay, no questions as yet. Let's do one more thing also and come back while just giving you all a little time. We just released a new gazette. So the Max Fax gazette was released, and it is meant to be a very traditional looking document, or what should I say, a gazette. That's what it is, and it is going to be weekly. And let's just release it here one round, and then do please remember to start typing. Yes, we are that gazette really took a lot of work, and the idea was to have something traditional among the many very modern or current things that we do. So, which was why the Max Fax Gazette came into existence, looking, I know, rather possibly outdated, but just thought it would be different. There are so many images of very hi-fi things, and especially with Chat GPT creating all these amazing images that look so crowded and so modern and so much.
Yeah.
I just thought we go a little traditional and go look, have a little different look,
Right. Right. A little change.
a little change, exactly. So that was why the setup of it looking like an old newspaper. Just thought about it. So everybody, have you any questions? I can see you are typing the IODC PC25, but do you have any questions for Patricia here? I have a question.
Sure.
So, or rather, maybe it's not really a question, it's just an observation. As a child, I had tongue thrusting,
Okay.
and with much, insistence and reminders from my brother, I managed to get over it. And it was perfectly fine, and my tongue very comfortably rested on my palate, and everything was fine. Uh, about 2 years back, when I was in the hospital and I was intubated for a long time, it was almost a month and a half.
Oh my.
Uh, by the time I came out, my tongue seems to have forgotten what it's supposed to do.
That can happen because they put you under anesthetic, and what they did is when they incubated you, they pushed your tongue down. Your tongue is trained to be up into the palate. Many people do not have their tongue on the palate, and so that also prevents the growth of your face. So, as a child, as an adult, we want to get that tongue back up there because the tongue stabilizes the body. So, yeah, your tongue thrust could come back. It could be less than it was before, but typically, people with a tongue thrust usually have a tongue tie, or at least that's been my experience.
Mm.
Not everybody, but typically. And the tongue has no room in the arch, so it needs to, it wants to get out. So it
True.
wants to get out of that space. It's like putting a Mack truck in a Volkswagen garage, it just doesn't fit.
True. I mean, thankfully, I don't have tongue tie, but and in fact, the problem was completely gone, and
Good.
I wasn't even aware of it any longer. And I normally don't have any problem with my lips closing or anything like that. But
Well,
now
that's nice.
suddenly I have a problem again, and
Mhm.
if I'm not thinking, my tongue is just behind my mandibular teeth, behind my lower
So,
incisors.
yeah, so orofacial myology, when we do our exercises or we do our first assessment, mine is quite long because I look at the whole body. Um, we are looking for any abnormality that could come back to haunt you, so to speak. Um, we typically see, I've seen many tongue thrusts, and it comes after the braces. Even after the braces have been put on, I see the tongue popping out every time they
Mm.
swallow. Um, it's just every person is different, and it just depends. Some tongues we can teach really quickly, and some tongues that just won't cooperate. I have, an adult right now that the tongue does not wanna listen, does not so it's neuromuscular, so you have to look in the mirror to tell the brain what the tongue and the muscles are supposed to do. So we have to break bad habits to and make them into good harmonizing habits. So as you saw with the rocks are all, all over the place, unbalanced. We want a balanced body, and that's what's going to give you a healthier life.
True. I have to find an exercise now to sort of retrain my tongue again.
Yeah, or do you have myofunctional therapists out there at all?
Not that I know of.
No? Okay,
No.
well, we're always available here in the States,
Mhm.
I see
And like
patients.
you said, you do work online, so that
Yeah,
comfortably takes away the problem of the distance. Yes.
right, because if the tongue isn't functioning right, you're not chewing right, you're not digesting properly.
Yes, and my
So,
salivation has gone all over the place.
yeah.
It's
So, and the doctors don't know about myofunctional therapy, and many oral surgeons do not use a myofunctional therapist, and I don't understand why, because we are so beneficial to help those patients before and after their surgeries. So, oral cancer surgeries, any of those, it would be advantageous to have a myofunctional therapist first, then do the surgery, and then have them come back afterwards.
it's very true.
Mhm.
And I think in that respect, we in dentistry are lagging a little behind because we have still not caught on to this thing about how myofunctional, uh, you know,
Right.
treatment
Well,
or movements are required.
I have a girlfriend that's been doing this for over 45 years here in the States. It's been underutilized. And so now that we know that myofunctional therapy is a benefit
Mm.
and can help people, there are parents or mothers that are seeking myofunctional therapists. They're not waiting for the doctors.
Yeah, it's a good thing. It's a good
Yeah,
thing.
yeah.
I think, like most things, it's when people know that something is there, then the need arises. So we have one question.
I read
Yes.
this. Is myofunctional therapy considered not, it is non-surgical, it is non-invasive. Eagles syndrome, you're gonna have to refresh my memory of what that is. But we see patients with strokes, with, Bell's palsy, any of those issues, any facial issues, but I do not recall what Eagles syndrome is. Do you know, Madonna?
Frankly, at this moment, I can't remember, but what
Yeah,
which is
put in
bad
there
for
if
me as
you
an oral pathologist. But my mind has not been working too well.
I was gonna
Is it
say
where the styloid?
The
uh,
process, the
the
styloid
process
process,
is longer or something.
the
Yes, it
muscle.
is correct. Elongation of the styloid process.
Yes, this can help because we are working with all those muscles, and those muscles are too long, and so we have to balance them out. Now, we're not going to go ahead and stretch the other side if one side or both sides are elongated. All the other muscles are going to be not in harmony, okay, because they're not used to that. That's not the way it should be. Um, I have not had a patient with Eagle syndrome, but it would be interesting to know. But it's all
Mm,
about the muscles. And that patient probably could be very tight. Even though that muscle's elongated in the styloid process, it could be tight other places.
other places. True. Has your work increased after COVID, where a lot of people got, were intubated and
Well, I did not close down with COVID because I
mm.
work out of my home. Um, I I just was steady Eddie the whole time.
No, what
So
I mean is a lot of people got, hospitalized
mhm.
because of COVID, and as a part of that, in fact, because a lot of people who are doing treating TMJ problems are saying that the problems have increased post COVID because of the changes or the damage that occurred during hospitalization. So I was just
Um,
wondering.
I have not received those clients. I'm happy to see them. They, again, if they were incubated or put on a
Hmm,
respirator, their tongue is down. That's the only way they can get in there. So there's nothing we can do about that. But
exactly.
I have not seen those clients as yet. And maybe some of them are just waking up to, wow, somebody could help me.
Yeah.
We have patients with long COVID
True, because I
and
see these comments and discussions going on LinkedIn with the groups where there's a lot of management of the temporomandibular joint problems, dysfunction. So there the discussions are going on, and I just thought that by it
so
may
go
take
ahead
some time before they reach you.
So go ahead and put my name in there, Mandana.
Yes, yes, I will do that. I will do that.
Tell them to check out
Yes,
musclesinharmony.com. There you
yes,
go.
that's a good idea. Okay, let's go and run the giveaway now. Okay, everybody, did you finish your typing? Okay, so I think you have, and I think we should run this. It's quite fun. Let's do this. Folks, we're gonna do it. If you have finished, it's good. There we go. Dr. Handavi, that's nice. Congratulations. So you get one registration. Do get in touch with me. I know we are connected. So get in touch with me, send me your email, and I will send you the link. Wonderful. Congratulations. And in case you are already registered, no worries. You can always give it away to someone else. So wonderful. And congratulations to you. Okay, so we have had our giveaway, and I think we are essentially all done. Yes, there are no questions. Let me just do this. Yes. So thank you so much, Pat.
Oh,
It
thank you for the
was,
opportunity. If anybody has any questions, they can email me, and I'm happy to help. And you guys all have a terrific evening, right? You're evening time, and I'm morning.
yes, you're going to have the rest of your day ahead of you. So
Yes,
have a
I
wonderful day.
thank you
Yes.
so much. You guys have a very nice day, and just watch that tongue.
Yes. Thank you. Thank
Thank you,
you.
Adina.
Okay. Welcome. Bye. Bye,
Bye.
everyone. Thank you for being with us. See you next time.